bronchus gives off lobular branch or lobar branches to the corresponding lung. So here's that tracheal bifurcation, which is the carina, and then the right main bronchus, left main bronchus, and then here's the trachea, the cervical and the thoracic portions. And it's a projection of the trachea onto the chest that they're drawing. And then here in figure B, it's an anterior view of the trachea. We've got the thyroid cartilage here, the median cricothyroid ligament, which makes sense because it's connecting the thyroid and the cricoid cartilage. We've got the tracheal cartilages and the annular ligaments holding those together. That right and left main bronchus, the different alveolar branches here coming off of the bronchi. And so it says right superior lobar bronchus, right middle lobar bronchus, and then right and left inferior lobar bronchi on the inside here. Here's the bifurcation, the carina, and then the left superior lobar bronchus. Here is a posterior view, and this here is called the arytenoid cartilage, and then more of the cricoid cartilage that kind of wraps around to the back. Here's a membranous posterior wall with tracheal glands, and then there's those tracheal cartilages again that we saw in the front, so it makes a ring. And then here's mucosa going through the inside of the trachea. And then this is the position of the carina at the tracheal bifurcation, the bronchi that we talked about already. And then already this early in the video, we've got a clinical box 10.3, foreign body aspiration. Toddlers are at particularly high risk of potentially fatal aspiration of foreign bodies. In general, foreign bodies are more likely to become lodged in the right main bronchus than the left. The left bronchus diverges more sharply at the tracheal bifurcation to pass more horizontally over the heart, whereas the right bronchus is relatively straight and more in line with the trachea. So it's kind of like that game, I don't know if anybody knows the game Plinko, where you put something into the top and it drops. Well, in this case, it's dropping and then it's more likely to go to the right. The conducting portion of the bronchial tree extends from the tracheal bifurcation to the terminal bronchial inclusive. The respiratory portion consists of the respiratory bronchiole, alveolar ducts, alveolar sacs, and alveoli. So here's the tree system. We've got a segmental bronchus with a cartilaginous plate, and then it breaks down further into a large subsegmental bronchus, and then to a small segmental bronchus, and then to a bronchial cartilage-free wall. Here's a terminal bronchiole, a respiratory bronchiole, and then the alveolar sacs are at the very end, and this is the respiratory portion of the airway. So this is carrying the air, and then this portion here is really where the gas exchange happens. And they've taken this boxed area here and blown it up over here. So that's what we're looking at in part B. And with that, there's a smooth muscle lattice that runs around the respiratory bronchiole, and there are also elastic fibers running within it. So it's kind of got a dual structure that's both flexible but functional. Here are the pulmonary alveolus, and then the respiratory bronchioles, which we already looked at. Here are the alveolar sacs, the intra-alveolar septums, so it's just a little border between each sac, and then a duct that's carrying air to these bundles of alveoli. And then this cluster of alveoli at the end is called an sinus. Let's see, what else do we want to say about that here? Really, this is taking, so this, and then this is blown up to here, and then this is happening at a cellular level in here. So this is the epithelial lining of the alveoli. So there's surfactant, which is on the outside of the alveoli, which allows the expansion and the contraction. So when you see the word surfactant, you can really also substitute a word that ends similarly, and that's lubricant. Real quick fun fact about surfactant. In infants, a lot of times the viability of infants is considered to be 25 leaks more often than not, and the reason for that is whenever they begin to develop their own surfactant. So if a baby is born prior to that, they really, really, really will have a tough time because the lungs won't expand and contract like they're supposed to because they're not naturally producing surfactant yet. Now, medicine has come up with kind of a workaround where I believe it's glucagon. You can give mom a shot of glucagon, and then that will cause that system to start firing, and then give that baby a much better chance of survival. But little fact aside, let's look at this a little bit more closely. So we've got the surfactant, the endothelial cell of the capillary. We've got the lumen of the capillary, which we saw here on the inside. And then there are type 2 pneumocytes, the lumen. Here are elastic fibers in the intraalveolar septum. So if it's not clear, what we're looking at here is this border right here is this border that's running between these individual alveoli sacs. And so it's talking about the movement of oxygen and how these individual alveoli function in relationship with each other. And I think they're going to build on it here with this clinical box 10.4. So respiratory compromise. The most common cause of respiratory compromise at the bronchial level is asthma. Compromise at the alveolar level may result from increased diffusion distance, decreased aeration or emphysema, or fluid infiltration. Mainly, the most common example of that is pneumonia. There's diffusion distance. Gaseous exchange takes place between the alveolar and capillary lumens in the alveoli, and that's what's detailed here. At these sites, the basement membranes of the capillary epithelial cells are fused with type 1 epithelial cells, lowering the exchange distance by 2.5 nanometers. Micrometers. Diseases that increase this diffusion distance, like edematous fluid collection or inflammation, result in compromised respiration. So what it's saying is when there's the presence of fluid, like edema or inflammation, it increases the distance here that the air has to travel between them, and that then makes the oxygenation of the blood more difficult because it's being processed more poorly by the body. The condition of the alveoli in diseases like emphysema, which occurs in chronic obstructive pulmonary disease known as COPD, alveoli are destroyed or damaged. This reduces the surface area available for gas exchange. So where it's talking about diffusion distance, it being more difficult to move between, in COPD, it's just gone. There's nothing there to process the air that's coming in. It's just coming in and going out with no exchange of oxygen with the red blood cells. And then this may actually talk about I just talked about production of surfactant. Surfactant is a protein phospholipid film that lowers the surface tension of the alveoli, making it easier for the lung to expand. The immature lungs of a preterm infant often fail to produce sufficient surfactant, leading to respiratory problems. Surfactant is produced and absorbed by alveolar epithelial cells or pneumocytes. Type 1 alveolar epithelial cells absorb surfactant, and type 2 produce it. So type 2 produce, type 1 recycle. So nice to know that I'm not just making up stuff here for you guys. I'm telling you the truth, I promise. Okay, respiratory mechanics. We talked about this a little bit in the section about the diaphragm, but it warrants reviewing again. Okay, so we got a paragraph here, so bear with me. The mechanics of respiration are based on a rhythmic increase and decrease in thoracic volume, with an associated expansion and contraction of the lungs. Inspiration in red, and then the contraction of the with inspiration in red, contraction of the diaphragm leaflets lowers the diaphragm into the inspiratory position, increasing the volume of the pleural cavity along the vertical axis, so it goes down. Contraction of the thoracic muscles, which are the external intercostals with the scalene recesses at a functional residual capacity, which is a resting position between inspiration and expiration. The lung does not fully occupy the pleural cavity. As the pleural cavity expands, a negative intrapleural pressure is generated. The air pressure differentiation results in an influx of air at inspiration. Expiration in blue. During passive expiration, the muscles of the thoracic cage relax and the diaphragm returns to its expiratory position, so it goes back up. Contraction of the lungs increases the pulmonary pressure and expels air from the lungs. For forcible expiration, the internal intercostal muscles with the transverse thoracic and subcostal mucosa can actively lower the ribcage more rapidly and to a greater extent than through passive elastic recoil. So, if anybody didn't follow that, basically what happens is the diaphragm will pull down and the muscles between your ribs will expand, and it will pull the lungs apart, and that causes negative pressure. So there's a void in the lungs all of a sudden, and air naturally will flow into that in the process called inspiration. And then kind of like, if anybody, this is kind of a dated reference, but if anybody's ever heard of a bellows, which is that thing that they used to compress to blow air on a fireplace to make a fire bigger. That's kind of like what the process of expiration is like. They close, the lungs close like a bellows, and it pushes the air out of your body. And which at that point is just carbon dioxide, so the body no longer needs it because the air exchange has already taken place. Alright, let's look at these diagrams, which are going to demonstrate pleural cavity expansion. So for inspiration, there's the expansion on the vertical axis, and it shows you the directions in which it expands. And it happens both on the transverse axis and the sagittal axis. And then it gives us an an anterior lateral view, highlighting the epigastric angle just for the purposes of orientation. And then on expiration, it's showing basically the same thing in reverse. The lungs are decreasing in size, the diaphragm is changing in position. And then there's the contraction of the on the sagittal axis as well. So this diagram is really just reinforcing this one. Continuing on over here, when the lung is at full inspiration, or lung expansion, the full inspiration, the pleura expand even down into that costodiaphragmatic recess, because if you're running and you really need to be pulling air, then your lungs need as much space as they can capitalize on to pull in as much air as possible. And then in comparison, you can see the diaphragm relaxing and positionally sliding up, decreasing the amount of space that the lungs even have, forcing them to contract and push that air out. As the volume of the lung changes with the thoracic cavity, the entire bronchial tree moves within the lung. These structural movements are more pronounced in portions of the bronchial tree distant from the pulmonary hilum. Alright, we've got ourselves another clinical box, so that's fun. Clinical box 10.5, pneumothorax. The pleural space is normally sealed from the outside environment. Entry to the parietal pleura, visceral pleura, or the lung allows air to enter the pleural cavity via a pneumothorax, or called a pneumothorax. The lung collapses due to its inherent elasticity, and the patient's ability to breathe is compromised. The uninjured lung continues to function under normal pressure variations, resulting in a mediastinal flutter. The mediastinum shifts toward the normal side during inspiration and returns to midline during expiration. Tension or valve pneumothorax occurs when a dramatically detached and displaced tissue covers the defect in the thoracic wall from the inside. This mobile flap allows air to enter but not escape the pleural cavity, causing a pressure buildup. The mediastinum shifts to the normal side, which may cause kinking of the great vessels and prevent the return of venous blood to the heart. Without treatment, tension pneumothorax is invariably fatal. So, let's see. Yeah, let's look at these here. And thankful for diagrams in case, if you're an auditory or a visual learner, we're going to try and hit both fronts here for you. So, normal inspiration and normal elasticity of the lung, the whole pressure differential here is completely compromised, and the lung just completely collapses. And the heart will shift over to this side because most of the force of the tension over here is just kind of pulling it over, and then this is kind of almost like a flag in the wind, really. And so, on expiration, there's really not a whole lot happening because it didn't withdraw air, so there's not any air to push out. And then the heart shifts back to this side because the pressure that's going back out. So, yeah, it says empty pleural cavity at atmospheric pressure. So whatever it is outside is what it is in your lungs. The pressure differential does not exist. Alright, now in a tension pneumothorax, we have the pleural defect on inspiration. So we're drawing air in, we're causing that cardiac shift, but then there is a flap or some kind of compensation by the body, whether usually it's inadvertent, like this says the mobile flap. So it's probably just another piece of pleura that kind of can flop back over it. And what's happening because of that is it's causing a buildup of pressure. It's like, just imagine breathing in and then not breathing out. In. It would be like a tire accepting more and more air pressure. And it's just displacing things more and more. It's causing the heart to shift over. And it says that it will cause, kinking of the great vessels. So the heart's right here. So you've got the aorta, the superior vena cava right up here in this area. So if the heart's getting pushed and pushed and pushed, it will kink it like a water hose, and that can be fatal if it's not treated. So, hopefully not a new fear unlocked for everybody, but it's real. Alright, now speaking of the great vessels, we've got the pulmonary arteries and veins, and you can see the relationship how a pneumothorax could impact these pulmonary arteries, the superior vena cava or the aortic arch right here. Let's get into them. The pulmonary trunk arises from the right ventricle and divides into a left and right pulmonary artery for each lung. The paired pulmonary vein opens into the left atrium on each side. The pulmonary arteries accompany and follow the branching of the bronchial tree, whereas the pulmonary veins do not, being located at the margins of the pulmonary lobules. Okay. So we see here the right pulmonary and left pulmonary artery, and then the trunk itself, which we can see also here. And then for the the pulmonary arteries and then the pulmonary veins are here. And that leads to the right internal jugular and left internal jugular, the right and left subclavian, the right brachiocephalic, which again is a feature only on the right side. And then, I'm thinking of another structure. I'm thinking of a different structure, sorry. Left brachiocephalic vein is on this side, superior vena cava, and then the right pulmonary veins and left pulmonary veins, and then there's that IVC, the inferior vena cava. And then this is just a distribution of the pulmonary arteries and veins. So this is everything that we've already looked at, just a different look at it, showing the relationship and building all the different aspects together. So we've got the pulmonary arteries, the pulmonary veins, we've got the trachea, and then the bronchi, and then getting down to the terminal bronchioles down here, and then the alveoli will be all scattered about here. originate from stagnant blood in the veins of the lower limbs and pelvis. Venous thromboemboli. So again, DVT. Deep vein thrombosis. Causes include immobilization, disordered blood coagulation, and trauma. Note, a thromboembulus is a thrombus or a blood clot that has migrated or embolized. So that's where the name comes from, embolize. So pulmonary embolism is an embolus or a mobile blood clot in the pulmonary region, pulmonary embolus. And then we've got the neurovasculature of the tracheobronchial tree. The pulmonary system is responsible for gaseous exchange within the lung. Pulmonary arteries in blue carry deoxygenated blood and follow the bronchial tree. The pulmonary vein and tributaries in red is the only vein in the body carrying oxygenated blood, which it receives from the alveolar capillaries at the periphery of the lobule. So again, what I told you about before, this portion of the body is the only one where it's flipped, where veins are carrying oxygenated blood and arteries deoxygenated. So you've got your bronchial artery and the branch of the pulmonary artery with deoxygenated blood. So this is an artery carrying oxygenated blood to supply oxygen to the alveoli or to the bronchial, not to be confused with the pulmonary artery, which is carrying deoxygenated blood from the lungs back out to be through the process of expiration to be pushed out. Here's a tributary of the pulmonary veins with oxygenated blood, the capillary bed on an alveolus here. So that's getting down to the granular level. And then here's a pulmonary alveolus as well. Here's the fibrous septum between pulmonary lobules. And then this in here is another look at another pulmonary alveolus. Here are the arteries of the tracheobronchial parasympathetic. We got the dorsal motor vagal nucleus, and that carries to the vagus nerve, which is going to go to all three portions as well. So, I think we'll go ahead and draw this video to a close here. We will go next to, so we've got some sectional anatomy, which we'll go through as that leads up to some radiographic imaging. So we've been looking at this on drawings, but next time we'll get to actually look at some real radiographic imaging to see what it looks like in reality as opposed to these drawings that we've been looking at. So if you enjoyed this video,